Alright, so I'm making these videos not like they really serve a huge purpose. For me, I drive 2 hours every day to get to and from school, so I need something to fill that time, and I don't want to waste time not studying. So I'm going to go ahead and start posting these. If you guys want to watch them, that's fine. If you don't, also fine. I'm not going to sit here and pretend like I know anything more than anybody else. But right now I'm going to go ahead and get started on this first video over the cardiac notes. This video is just going to encompass anti-hypertensives, and basically what I'm going to do is I'm going to give the run through of everything that's on the slide and then go through what I highlighted, because I highlighted what she told us to highlight, and then I'm going to talk about what I think that means for us on the test. I may be right, I may be wrong. Take it with a grain of salt. Again, if you don't like it, that's fine. If you don't want to watch, that's fine. And if I cuss and you don't like that either, shut it off. But it's whatever. So, all right, let's get into it. So, chapter 26 is hypertension. We all know what hypertension is. Overview. So, basically, here, let's look at this. So we need to know probably normal labs here, 120/80. Pre-hypertensive is 120 to 139 with a diastolic of 80 to 89. Stage 1. Systolic's 140 to 159. Diastolic is 90 to 99. And stage 2 is greater than 160 and over 100. So things that it's going to affect: heart, brain, kidneys. Lots of bad stuff happens from hypertension. I don't really think we need to know that. Really just focus on the medicine here. So skip that. Okay, so here are our main classes of drugs that we're going to use to treat hypertension. Angiotensin converting enzyme inhibitor, so ACE. Angiotensin 2 receptor blockers, or ARBs. Calcium channel blockers, and then direct renin inhibitors. So I think that's like maybe your beta blockers. That's later on. We'll get into that. All right, so we'll start with ACE, captopril and lisinopril. So the prils, those are really easy to remember. So captopril, lisinopril. The reason is you got this little guy up here in the corner coughing. That's called the pril cough. So PRIL, pril cough, and both those, captopril, lisinopril, end in pril. They're ACE inhibitors. Okay, so obviously these are antihypertensives. So expected uses: remodeling of heart muscle and blood vessel walls that impairs cardiovascular function, heart failure and hypertension. MI, left ventricular, I'm guessing heart failure, and then diabetic nephropathy. So basically all the stuff that causes hypertension. There's nothing special about this that really sticks out to me, but it's a lot of different indicated uses. So she did say we got to know all the expected actions for all of these drugs for the cardiovascular drug set. So for ACE inhibitors, captopril and lisinopril, the expected action is block the enzyme that normally converts angiotensin 1 to the potent vasoconstrictor angiotensin 2. Again, expected action for ACE inhibitors is block the enzyme that normally converts angiotensin 1 to the potent vasoconstrictor angiotensin 2. Okay. Adverse side effects of captopril and lisinopril: persistent cough, the pril cough, hyperkalemia, neutropenia, angioedema, glomerulonephritis, bronchospasm, orthostatic hypotension, dizziness, and loss of taste. Again, the adverse side effects are persistent cough, hyperkalemia, neutropenia, angioedema, glomerulonephritis, bronchospasm, orthostatic hypotension, dizziness, and loss of taste. Contraindications and cautions: pregnancy, there's a black box warning, the only one, and again, we always need to know our black box warning. Death to fetus. ACE inhibitors kill babies. Just remember that. You won't forget it now. So captopril and lisinopril, they kill babies. Remember that. And then nursing considerations are allopurinol and allosterin iron decreases the effectiveness. You take on an empty stomach 1 hour before, 2 hours after meal, kind of like our antibiotics. Avoid potassium. Over the counter cold medications, you want to avoid those too. It can be crushed. Contact provider with fever, rash, mouth sores, swelling on hands and feet. So, again, nursing considerations are allopurinol and allosterin iron decreases the effectiveness. Take on an empty stomach 1 hour before, 2 hours after meal. Avoid potassium and over the counter cold medications. It can be crushed. Contact provider with fever, rash, mouth sores, swelling on hands or feet. Okay, so why have what I have highlighted here? If you want to take a look at it, or if you're just listening, that's fine. But we already went through expected action. Again, is going to block the enzyme that normally converts angiotensin 1 to potent vasoconstrictor angiotensin 2. That's again across the board. We have to know expected action, so it's highlighted. Persistent cough, the prill cough. That makes the names easier to remember. We don't need to know, but it has to do with the type 2 surfactant in the alveoli. That's why it's causing that cough. We also have angioedema and bronchospasms highlighted. We have 3 things here in adverse side effects highlighted, so I would anticipate that maybe we're going to see this as a select all that apply. So maybe commit these to memory. So persistent cough, hyperkalemia, neutropenia, angioedema, glomerulonephritis, bronchospasms, orthostatic hypotension, dizziness, and loss of taste. Some of these are going to be easy to remember. It's just kind of like when you go from hyperthyroid to hypothyroid, same like hypertension to hypotension. So the orthostatic hypotension and the things that come along with it, like dizziness. But anyway, so I would take a look at those. That's what I'm going to do. Obviously, black box warning is highlighted. We always highlight those. Kills babies. And then she also did mention allopurinol, allosterin, iron decreases effectiveness. I'm going to turn down my gain here. All right, next. ARBs, angiotensin 2 receptor blockers. Angiotensin 2 receptor blockers, ARBs. Losartan and valsartan hydrochlorothiazide. So the sartans, those are your ARBs. So just remember that. Sartan, the ARBs, angiotensin 2 receptor blockers. Again, expected use. Hypertension, the drug effects in people with type 2 diabetes who have diabetic nephropathy and heart failure. So I don't know why she has the Sultan from Aladdin up there. He looks like he could be diabetic, so maybe remember it that way. I don't know. And if I offend you, shut it off. Expected action, so we have to know it. Expected action for ARBs, losartan and valsartan. Blocks vasoconstriction and aldosterone secreting effects of angiotensin 2 at various receptor sites and prevents angiotensin 2 from combining at various receptor sites. So I say again, expected action of losartan and valsartan hydrochlorothiazide, which are the ARBs. The expected action is blocks vasoconstriction and aldosterone secreting effects of angiotensin 2 at various receptor sites and prevents angiotensin 2 from combining at various receptor sites. I think the really big thing is it blocks angiotensin 2, and it's right there in the name, okay? And so if we go back and look, angiotensin 2 is a potent vasoconstrictor. Right there. So what that's going to do is keep your veins and arteries open wide and therefore decrease the pressure on the inside of them. That's how it's going to work, all right? So adverse side effects for angiotensin 2 receptor blockers are going to be dizziness. HA, as we found out, is headache, blurred vision, dyspepsia, impotence, hypo and hyperkalemia. I put 3.5 to 5.0. Those are the numbers you're going to want to know for the kalemias, which is your potassium concentration in your blood. I don't remember what the units were, but just know those numbers: 3.5 to 5.0 for hyper/hypokalemia. If it's outside that range, you need to know that. Hyperglycemia, renal failure, URI, photosensitivity, cough, multiple cramps or muscle cramps or weakness, heartburn, diarrhea, and angioedema. So again, adverse side effects of the ARBs are dizziness, headache, blurred vision, dyspepsia, impotence, hypo and hyperkalemia, which is 3.5 to 5.0, hyperglycemia, renal failure, URI. I don't remember what she said that was for. I'll have to look that up for the next video. Photosensitivity, cough, muscle cramps or weakness, heartburn, diarrhea, angioedema. This one also kills babies. So ACE and ARBs are baby killers. Not good. That's your black box warning. Pretty easy to remember. Those are the only contraindications for the both of them. And then nursing considerations: avoid grapefruit juice, licorice salt substitutes, and over-the-counter, I think, cold products. Again, St. John's wort. Notify provider of edema and position changes slowly. So probably orthostatic hypotension. So here we go. Back into losartan and valsartan. Again, we need the expected action. So angiotensin 2, it stops it from working and causing vasoconstriction, and aldosterone secreting effects. So if you think about it, angiotensin 1 goes to the lungs, where it's converted to angiotensin 2. That's why those ACE inhibitors cause that cough, that prill cough, because that conversion is going on in there. That angiotensin 2 is a vasoconstrictor, but as it goes through, it also works as a regulatory system to go back to the kidneys and say, hey, you need to secrete some aldosterone, which is also going to help decrease blood pressure. So it has it's a twofold effect thing here, the way the ARBs work. So think about those two things. So stops the vasoconstriction of ARBs and stops the aldosterone secreting effect of whatever angiotensin 2 does. Okay, so that's what it does. The reason I have impotence in green is I was looking through and I have starred in my notes here. It says don't take Viagra with antihypertensive. So I guess across the board, if you're on an antihypertensive, you got high blood pressure, don't take Viagra with them. And I would assume that's any male performance enhancing drug, just due to the fact that it will cause greater effects on or cause hypotension. Next is avoid grapefruit juice, licorice, salt substitute, and over-the-counter products and St. John's wort. I see a select all that apply there myself of things that, teaching and interventions, things to avoid. That's a big list. And it kind of encompasses a list that we've seen in a lot of drugs. So think about that. And with that being said, we'll move on. I think one other thing she said is, she did make note of the hyperglycemia. So be looking for that. Next is calcium channel blockers. Amlodipine and felodipine, and I'm not even going to attempt that. It ends in pine or pine. So that's how you can remember your calcium channel blockers. They all end in pine. If we go back again, so ACE inhibitors are prill, ARBs are sartans, calcium channel blockers are pines. Again, hypertension alone or in combination with other antihypertensive, chronic stable angina, hypertension, catecholamine beta blocker, to prevent tachycardia and variant angina. So calcium channel blockers also work in slowing down the heart with the way that calcium is used in those muscle cells. So think about that as an alternative effect. Not that you really need it right now. We'll see when we get the test review. But the expected action of the calcium channel blockers, amlodipine and felodipine, and the other pain, expected action is inhibits the influx of calcium ions across cardiac and smooth muscle during depolarization, resulting in relaxation and vasodilation. Again, expected action is inhibits the influx of calcium ions across the cardiac and smooth muscle during depolarization, resulting in relaxation and vasodilation. Adverse side effects of calcium channel blockers are headache, drowsiness, fatigue, dizziness, edema of the hands, ankles, and feet, flushing, palpitations, nausea, vomiting, and abdominal pain, bleeding gums, cough, dyspnea, nocturia, sexual difficulties, bradycardia, and weight gain. So again, adverse side effects here are headache, drowsiness, fatigue, dizziness, edema of the hands, ankles, and feet, flushing, palpitations, nausea, vomiting, and abdominal pain, bleeding gums, cough, dyspnea, nocturia, sexual difficulties, bradycardia, and weight gain. Contraindications or cautions, hypersensitivity. Children, I'm guessing, shouldn't have it. If you've had an acute myocardial infarction, unstable angina, aortic stenosis, and then HF and GERD. So I don't know what HF is, but GERD is, acid reflux, all that. So don't take them if you got those things going on. Nursing considerations, interventions, and teachings. Monitor daily pulses and hold if under 60 beats per minute and contact provider. Change position slowly. Avoid grapefruit juice. Again, over-the-counter cold medications can take with meals. Don't stop abruptly and take a full glass of water. Do not crush. So I think we have across the board for the first three with ACEs, ARBs, and calcium channel blockers. I'm seeing the pattern in the over-the-counter cold medication, and then for calcium channel blockers, again, we have grapefruit juice. I think ARBs is probably over-the-counter cold medication. It just says over-the-counter. That's pretty vague, so I'm gonna ask for clarification. So when we do part 2 of this video, we'll know. But here's why we have what we have highlighted. She mentioned all these things. I added weight gain here under adverse side effects. So edema of the hands, ankles, and feet, and weight gain were in the things that she said about this specifically. The hold under 60 beats per minute. That seems to be across the board for all of the antihypertensives is something that she's kind of put out. And then grapefruit juice, over-the-counter cold medications, again, that kind of falls in there. And then don't crush. What I see for this set of drugs is I see something about adverse side effects. Select all that apply. I think they're all going to have to do with one another, where it's the edema of hands, ankles, and feet, and weight gain, fluid retention type stuff. And then maybe we might see something about taking diuretic with this. That's just kind of what I'm forecasting. I don't know. I'm going to talk to her about it, though. All right. Next, we have alpha-1 adrenergic, I don't know if I'm saying that right, blockers, doxycycline, and prazosin. So they all end in sin. So yeah, expected use, again, hypertension, benign prostatic hyperplasia. I thought that was kind of something to take note of, but she never mentioned it, so we'll see. I don't even know what that word is. And Raynaud's disease. So yeah, this is kind of a unique one. Expected action: blocks vasoconstriction and blood vessels, venous and arterial dilation. Doesn't really say how. I might dig into that a little bit further, but I don't know if I need to. So again, expected action of alpha-1 adrenergic blockers, doxycycline and prazosin and terazosin, I don't know. Okay, the expected action is blocks vasoconstriction. in blood vessels, venous and arterial dilation. So it causes venous and arterial dilation. Okay. Adverse side effects: orthostatic hypotension, reflex tachycardia, nasal congestion, headache, tiredness, vertigo, tinnitus, priapism, nausea, vomiting, diarrhea, impotence, which is the opposite of priapism. So, orthostatic hypotension, reflex tachycardia, nasal congestion, headache, tiredness, vertigo, tinnitus, priapism, nausea, vomiting, diarrhea, and impotence. Cautions, contraindication is history of syncope, heart disease, precautions in renal and hepatic disease, and eye problems. Okay, so here we go. Nursing considerations. I think this is where the question is going to come in here for the alpha-1 adrenergic blockers, the doxazine and prazosin. Nursing considerations. Take at bedtime. Viagra will increase hypotension. Goes back to what I said earlier. Avoid changing positions quickly. Can have first dose syncope. Stay recumbent for 90 minutes. Monitor BP, weight, and bun and creatinine. So there we go. I think we're going to definitely see a question about can have first dose syncope. Stay recumbent for 90 minutes. That goes back into history of syncope and why it's highlighted. Again, just remember, don't take Viagra with any of these antihypertensives. Take at bedtime and monitor blood pressure, weight, bun, and creatinine. Let me see. Pause this for a second. Sorry about that. Yeah, that's it. We'll skip. I think we're good. Oh, what the hell is going on here? I don't know what I did. Okay. Anyway, there's something. Oh, my notebook was on my keyboard, and I think I just biffed this whole thing. Oh my God, what did you do? Oh, you dummy. Okay, here we go. Back to where we were. Alpha-2 agonists, clonidine and methylodopa. I don't really have a good way to remember these names. Use is in hypertension. Expected action is decreased sympathetic stimulation, bradycardia, decreases cardiac output, vasodilation, peripheral blood vessels. Again, expected action is decreased sympathetic stimulation, bradycardia, decreased cardiac output, and vasodilation of peripheral blood vessels. Adverse side effects for clonidine and methodopa, which are the alpha-2 agonists, are drowsiness, dizziness, dry mouth, and eyes, constipation, lightheadedness, fatigue, hyperglycemia, impotence, nausea, vomiting, rash, CHF, I forget what that was again. Orthostatic hypotension, again, we see that. Cautions, contraindications, anticoagulation therapy precautions with myocardial infarction, DM, renal or liver disease, and then nursing considerations, interventions, and teaching. Take at bedtime. Again, we take all these at bedtime. Why? Because our body has to get used to it, and if it causes orthostatic hypotension, we could fall. So take at bedtime. For dry mouth, you can have hard candy and sips of water. Avoid changing position quickly. And again, orthostatic hypotension. Avoid with alcohol, smoking, CNS depressants, or over-the-counter meds. Avoid high-sodium foods and monitor for fluid retention. I'm going to pause. I got to go. All right. Had to take a break there for a second. Have some dinner, all that. Beta blockers end in OLOL, not just LOL. So atenolol, metoprolol, and propanolol, they all end in OLOL. And the reason I point that out is if you go to the next page, and they're the alpha beta adrenergic blockers, adrenergic. I can't talk. They also end in LOL, but it's ILOL and ALOL. So again, beta blockers are all OLOL. So atenolol, metoprolol, and propanolol are your beta blockers, and they're used for hypertension, MI, and prophylaxis of angina. So, the expected action for beta blockers. I'm going to pause. I think I'm going to shut my. Sorry, I had other stuff running in the background there. Expected action for beta blockers are decreased cardiac output and contractility, suppress reflex tachycardia. So again, expected action for the beta blockers are decrease cardiac output / contractility and suppress reflex tachycardia. Adverse side effects, we have nothing highlighted here for now, but bradycardia, coughing at night, SOA, whatever that is, rebound angina with sudden withdrawal, masked signs of hypoglycemia, insomnia, impotence, tremor, and confusion. Let me look. I think maybe the masking. Yes, masks signs of hypoglycemia. I remember her saying something about that. So we'll go ahead and highlight it. So adverse side effects, again, bradycardia, coughing at night, SOA, rebound angina with sudden withdrawal, masks signs of hypoglycemia, insomnia, impotence, tremor, and confusion. So big thing there is going to be checking blood sugars right there at the bottom. So check blood sugars, because if you're not showing any signs or symptoms of hypoglycemia, how would you know if you have it? Cautions, contraindications, sinus bradycardia, again, we're seeing that twice, PVD, Raynaud's syndrome, precautions with COPD or asthma, renal and liver, DM, whatever that is. I hate all of these abbreviations here. It's annoying. Okay, so again, cautions, contraindications, sinus bradycardia, PVD, Raynaud's syndrome, precautions of COPD or asthma, renal, liver, DM. Nursing considerations, interventions, and teaching. Monitor heart rate daily. Hold under 60. Again, there's another one that if it's under 60, hold it. Take at bedtime. Another one, again, at bedtime. Do not stop abruptly. Antacids decrease absorption, may mask hypoglycemia. If directed, check blood sugar, limit alcohol smoking, and sodium intake. All those seem pretty standard for something that treats hypertension, so there we go. Last but not least is alpha-beta adrenergic blockers. I don't know how many times I'm going to have to say that word before I get it, but carvedilol and labetalol, they're also LOLs, but again, they're ILOL and ALOL, so alpha beta blockers. Expected action, vasodilation, and decrease heart rate and contractility. Expected use, hypertension, heart failure, LV dysfunction after MI, and cardiomyopathy. So again, the expected action is vasodilation, decrease heart rate and contractility. Adverse side effects, dizziness, bradycardia, hypertension, impotence, hyperglycemia, paresthesia, headache, increased LFT, bronchospasms, edema, and thrombocytopenia. Again, adverse side effects, dizziness, bradycardia, hypotension, impotence, hyperglycemia, paresthesia, headache, increased LFT, bronchospasms, edema, and thrombocytopenia. And these again are for alpha beta adrenergic blockers. Adrenergic blockers, alpha and beta. Okay. Cautions, contraindications, severe unstable heart failure, asthma or respiratory disorders, heart block, cardiogenic shock, precautions, DM, liver or renal, and peripheral vascular disease and depression. Okay, so those are your contraindications and cautions. And nursing considerations, interventions, and teaching. Report dizziness, check pulse daily. Lying to standing position carefully, hyperglycemia and digoxin toxicity. Do not stop abruptly. take with food, and can be crushed. So hyperglycemia and digoxin toxicity are highlighted. Take with food and can be crushed are highlighted as well. Those are the only two real highlighted things so far that she talked about for AB blockers. So that is the end of antihypertensives, and I think I will make like a audio recording, and what I'll do is I'll just say a drug class, the name, and then expect and like how to remember that's what it is, and then expected action. I'll say it, give a pause, then if you're listening or whatever while you're jogging, whatever you're doing, you can say it back, do it again, same thing through all the bullet points, but I won't break it down into like this is what's highlighted, this isn't. So next up we'll be getting into dysrhythmias. That'll be the next video. So yep.